Hi everybody, and welcome to our module on scleroderma. Scleroderma is an autoimmune disorder, and it also goes by the name systemic sclerosis, and the reason it gets this name is because stiff, hardened tissues develop throughout the body. That's sclerosis. The skin is almost always involved, as are many other organs, as we'll see in the rest of this module. Systemic sclerosis has a complex pathophysiology that's incompletely understood. It begins with an element of endothelial cell damage. The trigger is unclear, and this leads to antibody production and cytokines, which can lead to more tissue damage. What's unusual about scleroderma as an autoimmune disease is that the result of autoimmune activity is fibroblast activation. Most autoimmune diseases lead to tissue destruction through antibodies and complement and white blood cells, but in scleroderma, what you get is fibroblast activation, and this results in excess collagen deposition, and that's what results in the sclerosis in tissues throughout the body. The most common demographic for scleroderma is women. This is true of most autoimmune diseases, and the peak onset is about 30 to 50 years old. And it presents in two distinct clinical syndromes. The first syndrome is called the diffuse form of scleroderma, and the second syndrome is called the limited form, which also goes by the name of CREST, which I'll explain in a few slides. Diffuse scleroderma gets its name because there is diffuse skin thickening. As we will see, in the limited form, the skin thickening is limited to the hands and the face. Another characteristic feature of scleroderma is Raynaud's phenomena. This is vasoconstriction and ischemia of the hands. We'll talk more about this in a minute. This is often the initial sign, so people who get scleroderma will have Raynaud's syndrome for a period of time by itself, and then later other signs and symptoms of diffuse scleroderma will develop. Another characteristic of the diffuse form of scleroderma is early involvement of the visceral organs. Renal disease is common. This can lead to renal failure. The GI tract can become involved. This can lead to dysmotility and heartburn. The heart can become involved. Patients with scleroderma can develop pericarditis and myocarditis, and also conduction system diseases like left and right bundle branch blocks and even AV node blocks. They can also get development of symptoms in their joints and muscles. This can consist of arthralgias and myalgias. One of the most lethal features of scleroderma is pulmonary hypertension. The pressures in the pulmonary artery system can elevate, and this can progress to right heart failure. These patients can present with signs of right heart failure like an RV heave, elevated jugular veins, pitting edema in the legs. Patients with scleroderma are routinely monitored with an echocardiogram. This is an ultrasound picture of the heart that allows you to estimate the pulmonary pressure, and they're monitored because early and aggressive treatment of pulmonary hypertension can be life-saving. In addition to the pulmonary hypertension, patients with scleroderma can develop interstitial lung disease when fibrous tissue develops inside the lungs. Scleroderma renal crisis is a life-threatening complication of the diffuse form of scleroderma. This often happens early in the disease. Patients will develop an acute worsening of renal function and marked hypertension. They often present to the hospital feeling very unwell with very high blood pressures. This used to be a fatal condition until ACE inhibitors came around. It turns out that this condition responds very favorably to treatment with ACE inhibitors, and that's the treatment of choice for patients with diffuse scleroderma who present in scleroderma renal crisis. Now we'll talk about the limited form of scleroderma, which also goes by the name of CREST, and it's called limited because there's limited skin involvement. The skin sclerosis is usually restricted to the hands. Sometimes it also occurs on the distal forearms, the face, or the neck. And the reason it's called CREST is because the 5 hallmark symptoms of the limited form are calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasias. Now, all of these can occur in the diffuse form as well, but they are the main symptoms of the limited form, and that's why it goes by the mnemonic CREST. Calcinosis consists of calcium deposits in the subcutaneous tissue, and this will present in patients with the limited form of scleroderma as bumps on their elbows, knees, and fingers. Sometimes the skin will break from the calcium deposits and it will leak chalky white fluid. And the way this often is picked up is by x-rays done on the hands. These may show soft tissue calcifications, and that's evidence of calcinosis, the C in the CREST of the limited form of scleroderma. We mentioned Raynaud's phenomena before in the diffuse form because it can occur in the diffuse form of scleroderma. It also occurs in lupus and other autoimmune diseases, as well as a primary disorder by itself. People who have Raynaud's phenomena will develop white-blue fingertips, especially on exposure to cold. Raynaud's occurs because of vasospasm in the arteries that lead to ischemia, and when you expose yourself to cold air, the vessels naturally constrict, and that can trigger the Raynaud's phenomena. This is a picture of someone with Raynaud's, and you can see that a couple of their fingertips here are white, and that's because of vasoconstriction. This can be very painful. People who have scleroderma often don't go out in the cold, or if they do, they wear very warm gloves because the cold can make their hands hurt a lot. This can lead to something called digital ulcers or fingertip ulcers. They can get an ulceration of the skin and it can become infected. This is often the first sign of scleroderma. I mentioned this before. In the limited form, patients will often develop Raynaud's for years or even decades by itself until the other crest symptoms begin to develop. And as I mentioned before, you can see Raynaud's phenomena in lots of other conditions. If you see this in a board question, it doesn't necessarily mean they're describing scleroderma. It can be isolated by itself, or it can occur with other autoimmune disorders, especially in lupus. Esophageal dysmotility is the third hallmark symptom of CREST. It is the E in the word CREST. This will present among patients as difficulty swallowing. This is due to dysmotility that results from collagen deposition in the esophagus. The other symptom that's characteristic of the esophageal problems in CREST is reflux or heartburn, and this occurs because the lower esophageal sphincter becomes hypotonic or incompetent. This is easier to understand with a picture. At the bottom of the esophagus, there is a muscular sphincter that keeps the lower esophagus tight so that stomach acids don't reflux up into the esophagus. In scleroderma, collagen deposition disrupts the muscular fibers of the sphincter. This allows stomach acids to get back up into the esophagus, and this leads to the symptoms of heartburn. I've bolded the word hypotonia here because that's a characteristic feature of esophageal dysmotility in scleroderma. You can do a test called esophageal manometry where you measure the tone of the lower esophageal sphincter, and that tone will be decreased. In other words, there will be hypotonia in scleroderma, and this is in contrast to another esophageal condition called achalasia, where you have hypertonicity and increased tone of the lower esophageal sphincter. Sclerodactyly is fibrosis of the skin of the hands. It often begins as the fingers becoming puffy and difficult to bend. This is often what makes people seek out medical attention. Later, as the disease progresses, the skin often becomes shiny and it gets very thickened. You won't be able to pinch the skin of a patient who has sclerodactyly. The fingers also lose their wrinkles over time. If it gets very severe, the skin can become so stiff that their hands become like claws. And you can also see this in the diffuse type. All of these symptoms of CREST can also occur in the diffuse type. One of the most striking features of sclerodactyly occurs when you shake the hands of a patient with scleroderma. If you ever get to do that, you will see that their hands feel almost like they are wooden from the disease. Telangiectasias are the final feature of CREST. These are skin lesions that result from dilated capillaries. They classically present on the face, but you can also find them on the hands and on the mucous membranes like inside the mouth on the cheeks. This is a picture of telangiectasias on the mouth of a man. Many women with scleroderma develop them on the face, especially on the cheeks and on the forehead, and they often wear lots of makeup to cover up the telangiectasias on their face. In general, the limited form of scleroderma has a more favorable prognosis than the diffuse form. In particular, limited scleroderma rarely involves the heart or the kidneys, which are the source of much of the morbidity and mortality in diffuse disease. The main risk for people who have the limited form is pulmonary disease. This is the leading cause of death. Just like in diffuse disease, patients with CREST can develop pulmonary hypertension and interstitial lung disease, and they need screening with echocardiography and treatment for these conditions if they develop. There are a number of antibody tests that are used to diagnose scleroderma. First of all, the anti-nuclear antibody, or the ANA, can be elevated in this condition. This is not a specific finding. You may know this is also an abnormal antibody test in lupus and many other autoimmune diseases. There is an antibody called anti-topoisomerase 1. It's also called anti-SCL70. This antibody is elevated in patients with diffuse scleroderma. The anti-centromere antibody is elevated in patients with the limited disease. Many people remember this by thinking of the C in CREST is equal to centromere for anti-centromere antibodies. And then finally, there is an antibody called anti-RNA polymerase 3. This is elevated in diffuse disease, and it's associated with rapidly progressive skin involvement. It's also associated with increased risk of developing scleroderma renal crisis. Unlike other autoimmune diseases, scleroderma is rarely treated with anti-inflammatory drugs. For scleroderma, the treatment is usually aimed at the organ system that's involved. For example, if people have problems with the esophagus, they can be treated with proton pump inhibitors to limit the heartburn. Raynaud's phenomena can be treated with calcium channel blockers, and pulmonary symptoms can be treated with many different pulmonary hypertension drugs. Immunosuppressants have a very limited role. They have little proven benefit. They're sometimes used in rare special cases, but it's very uncommon to see people with scleroderma on steroids and other anti-inflammatory drugs. You should be aware that primary biliary cirrhosis is associated with scleroderma. This is a liver condition where there is T-cell mediated destruction of small bile ducts, and it often presents with jaundice, fatigue, and itching, and it can lead to cirrhosis and liver failure if left untreated. These patients have abnormal blood tests like elevated conjugated bilirubin and elevated ALK Phos. About 5 to 15% of patients have the limited form of scleroderma when they also have primary biliary cirrhosis. It's also associated with a number of other autoimmune diseases, including Sjogren's, lupus, and RA. And I've bolded Sjogren's on the screen here because up to half of patients with primary biliary cirrhosis can develop Sjogren's syndrome symptoms. And then finally, it's also associated with thyroid disease, Hashimoto's thyroiditis. And that concludes our module on scleroderma.